Welcome to today's Grand Rounds, which is Journal Club. Hope everyone's doing well. Just a couple of quick announcements before we get to the divisions. Everyone remember to register for the Bob Trot if you have not done so already. It will be held on the Greenway in a socially distanced manner to support multiple charities through the nonprofit organization that Dr. Allen spearheaded, that we are much appreciative for our Stagger Strong effort. All right, Dr. Jane, I'll turn it over to you for Journal Club unless anyone else has any last minute announcements. All right, thanks.
All right, thank you, Chad. And so today we have Journal Club, and we are doing a urogynecology themed Journal Club, or pelvic medicine and reconstructive surgery. And Doctors Huntley and Lanzer have graciously agreed to help and moderate. And we are going to be hearing from Doctors Wannamaker and Dr. Griswold, and they are going to be presenting articles, one talking about Flomax to help with urinary retention, and the other looking at vaginal pessaries. So without further ado, I'd like to have us turn our attention to, I'm not sure who is speaking first because I'm not there.
Looks like Dr. Griswold.
Griswold. Okay, so we'll turn our attention over to Dr. Griswold.
Oh, actually, it's me. It's Louise. We're both together on her because we're trying to figure out how to do this.
Okay.
Does any? Can we? How do you share the screen?
Yeah, we could see your screen.
Yeah.
Now we can't.
Oh, you could and I can't. Okay. Can you see it now?
Yeah.
Yes.
Yep, we got you.
Okay, and then we want to do presenter view.
Sure.
Okay.
All right, we'll see how this goes. Okay, so for anyone who's on here that I haven't met, I'm Louise Wannamaker. So my journal was Tamsulosin to prevent postoperative urinary retention after female pelvic reconstructive surgery. So some of the background on this study, postoperative urinary retention, which is further called POR for the duration, it has an incidence of 14 to 16% in patients undergoing any surgical procedure. It has an incidence of 21 to 50% in patients undergoing female pelvic reconstructive surgery. It ends up with having a negative impact on patients with increased risk of urinary tract infection, increased healthcare costs, as well as significantly decreased patient satisfaction. Previously, there have not been any effective strategies for preventing POR in the high-risk field of FPRS. Some of the potential causes have been thought to be surgical disruption of the autonomic coordination required for voiding, negative impacts of anesthetic agents and narcotics under detrusor contractility, and specifically surgical technique used for FPRS can lead to pain and disruption of the local autonomic nervous system, which in turn causes an increased sympathetic stimulation to the bladder outlet, which then leads to inhibiting urethral relaxation and bladder emptying. So why did they choose Tamsulosin, also known as Flomax, for this study? So the bladder neck and urethra are rich in alpha adrenergic receptors. There's been previous evidence that the prophylactic use of antagonists before the onset of symptoms may decrease the incidence of POR after urologic and colorectal surgery in men. However, there has not been clear evidence showing effectiveness of these medicines in women. There were 3 prior studies using non-selective alpha adrenergic receptor antagonists, which had contraindicated results. However, they used phenoxybenzamine, which is no longer indicated. Previously, there's been some evidence showing that selective alpha AR antagonists, such as Tamsulosin, seemed to be superior in preventing POR in men. However, this had not been studied in females. They have been shown to improve relaxation of the female bladder, neck, and urethra. So the study was a retrospective matched cohort study that included patients who underwent FPRS at a single academic institution between January 2016 and March 2018. They picked this date range to ensure that they had a large enough patient population. All the procedures were performed by the same two FPRS board certified surgeons. And the aim of the study was to determine the effect of prophylactic use of Tamsulosin on postoperative urinary retention in female patients after pelvic reconstructive surgery. And they hypothesized that this would decrease the rate of POR in this particular high-risk population. For patients to be included, they had to be admitted for a minimum of 23-hour observation immediately after surgery for apical pelvic organ prolapse with or without a mid-urethral sling. They were excluded if they were discharged on the day of surgery, and if they only underwent a mid-urethral sling or colporography without apical suspension. And then patients with any intraoperative complication that where they needed prolonged postoperative bladder drainage were also excluded. Out of the included patients, they were categorized by one of 6 primary procedures performed: uterosacral ligament suspension with mid-urethral sling as well as without, sacrospinous ligament suspension with mid-urethral sling and without, sacrocolpopexy, and hysterectomy with mid-urethral sling. And these percentages listed were the same in both the Tamsulosin group as well as the control group. The group was matched to historical controls at a 1:4 ratio, where the procedure was performed using information from the operative reports before looking at any data regarding voiding or postoperative outcomes. And like I noted previously, all of these surgeries occurred within 2 years of each other. So postoperative urinary retention in this study was defined by failure of the initial voiding trial only. They backfilled the bladder up to 300 mLs, removed the catheter, and had the patient void within 15 minutes to measure post-void residual volume. Anything less than 100 mLs or 50% of the voiding volume was considered passing. As a secondary outcome, they looked at patients who later developed delayed urinary retention after passing the initial voiding trial. The calculations they used, some of which are medians and interquartile ranges to look at continuous variables with normal distribution and skewed data. Categorical variables were documented in counts and percentages. Chi-square and Fisher test were used for pairwise comparison of categorical variables between the control and Tamsulosin groups. Wilcoxon rank sum test was used for a pairwise comparison of continuous variables between the control and Tamsulosin groups. And then a univariate logistic regression was performed, and any variable that was associated with the primary outcome of POR with a p-value of less than or equal to 0.2 was controlled for in the final regression model as a potential co-founder. They also used a multivariable logistic regression to identify independent predictors of POR. They then went on to do a subgroup analysis of patients who underwent mid-urethral sling placement, and that was done in a similar fashion with the same calculations. So these were the results. Table 1 shows comparison of demographic and basic clinical information between the group. The only 2 categories with significant p-values were age and postmenopausal state. So patients who received Tamsulosin were younger and less likely to be postmenopausal. And this was out of 35 in the Tamsulosin group with 140 controls. Table 2 shows a comparison of voiding characteristics and urodynamic parameters. They did not find any significant differences in relevant preoperative voiding characteristics or urodynamic findings. In Table 3, it demonstrates the comparison of intraoperative details between the groups. Out of these, patients who received Tamsulosin were less likely to undergo anterior repair and more likely to undergo laparoscopic hysterectomy as part of their procedure, with p-values both of 0.05. This Table 4, which demonstrates the comparison of postoperative voiding outcomes. As you can see, the poor postoperative urinary retention has a p-value of 0.004, significant value with decreased rate in the Tamsulosin group. PVR value is also significantly decreased. And then interestingly, delayed urinary retention was actually increased in the Tamsulosin group with a significant p-value. So they did a univariate logistic regression, which revealed potential confounders of the primary outcome with a p-value of less than 0.2, including BMI, POP-Q, BA value, preoperative PVR, performance of hysterectomy, performance of anterior repair, and voiding trial occurrence on the day of surgery. Because of this, they then controlled for those in a multivariable logistic regression. The final regression model identified Tamsulosin used to be the only independent predictor of poor with a significant protective effect. P-value of 0.03. They then did a subgroup analysis of the 70 patients who underwent midurethral sling to evaluate the effectiveness of Tamsulosin just in that population. 14 of those patients received Tamsulosin, whereas 56 did not. Of the patients who received Tamsulosin, they were significantly less likely to develop poor than those who did not receive the medication. And they did not do a logistic regression of that subgroup. So as far as positive aspects of the study, with the exception of age and postmenopausal status, the groups were quite similar with no significant differences in comorbidities, BMI, preoperative diagnosis, their prolapse, or preoperative voiding function. They tried to address selection bias by matching patients to a large control cohort by primary surgical procedure, as well as presence of having a midurethral sling performed. They included only the most recent match, and they kept the time frame within 2 years of each other. They also tried to address testing bias. The study noted that providers may have a subconscious desire to not diagnose patients with poor, so they used an active voiding trial that was standardized in their practice and provides an objective PVR value. They also limited the primary outcome to the objective PVR value and did not include those who developed delayed urinary retention. As far as negative aspects, this was an unblinded retrospective study. There are slightly higher rates of anterior repair and laparoscopic hysterectomy in the control cohort. A portion of the control cohort underwent voiding trial on the day of surgery, whereas Tamsulosin patients all underwent voiding trial on postoperative day 1. However, it has been previously noted that those aren't significant differences. Also, the half-life of Tamsulosin is 9 to 13 hours. So clinical outcomes beyond this period cannot be reliably attributed to this medication. So inclusion of patients with delayed urinary retention in the primary outcome would not be valid. And so in an attempt to improve internal validation, it impacts the ability to generalize the results. So as far as moving forward in our field, the use of Tamsulosin was associated with a significantly decreased rate of port in the studied population. A subgroup analysis was performed on patients who underwent concomitant midurethral sling in an attempt to study those at highest risk, and showed that they similarly benefited from a decreased rate of developing pore when taking prophylactic medication. Should recommend that prospective studies be performed to assess the efficacy of Tamsulosin to prevent pore after female pelvic reconstructive surgery, and further explore the proper extent of treatment, as it's unclear the duration and timing of when to give the medication. But overall, it looks like alpha adrenergic receptor antagonists seem to be promising therapy in women.
That was a great job, Dr. Wannamaker, and the breakdown and interpretation of this article. Can you guys hear me okay?
Yes.
Okay. One of the reasons why I selected this article is because I was really excited. Something that Dr. Griswold, Dr. Wannamaker pointed out at the beginning is some of the limitations with postoperative urinary retention. And one of the biggest ones is just really decreased patient satisfaction. You know, when I talk to my patients about surgery and the risks associated with it, they don't care about the potential bowel injury or the prolonged stay from bleeding or significant infection. They don't care about any of that. Their primary concern that they talk about over and over again, the day of surgery, preoperatively, everything, is going home with a catheter. So anything that could potentially decrease that risk would just make me extremely excited. And I saw this article, I was really excited. And so one question I want to ask to the residents is, do you all think that based on the information presented in this article, do you think that we should change our practice and give Tamsulosin to our Urogyn patient population here at AU? Anybody other than the presenters? I'm going to pick on someone if I don't have a volunteer. Dr. DeVoe, you don't count.
Resident.
I feel like it's a reasonable, it's a low risk thing to give it for a potential, improved satisfaction for the patient.
Right. One of the things that we do know is that there are a few reasons why we may not consider. One is because this is an off-label use. It's only been studied and FDA approved for men with BPH. So that's an off-label use. There may be some issues with insurance. And then the other is that one of the common side effects that can be mitigated in some ways, but one of the common side effects is dizziness with use. And the other thing that we don't know is the best regimen to give. So one thing in this study, the reason why I couldn't understand why they would exclude patients that were discharged on post-op day 0, but the way that they administered the medication, they gave 2 doses. I believe it was 3 and 15 hours after surgery. And for our population, that's not really applicable because since COVID, we've been sending every single one of our patients home on post-operative day 0. So that's one of the limitations. And I felt like this study was just riddled with so many issues associated with retrospective studies. And so the thing I was really excited about is that this group has since done a really nicely designed prospective double-blinded RCT. Beautifully done. It was presented at AUGS in October. It has not yet been published, but I think this is just a great, great example of the limitations of a retrospective study and what can be done in a prospective study. One of the other issues with this is that there was a difference in the age. So younger patients were in the Tamsulosin group. And so you could explain that maybe they have less nerve damage and that they're going to perform better anyway. But in their prospective study, all of those issues were eliminated and the findings remained consistent. So the overall rate of postoperative retention decreased from almost 30% without Tamsulosin to 8% with it. That is remarkable to me. So because of that study, I have, Dr. Lanzer and I have started giving Tamsulosin to our patients, and the regimen was different. The evidence shown in the colorectal neurologic literature, the ideal regimen would be to start earlier, prior to the insult, so prior to surgery. So we actually start, we give it to the patients 3 days prior to their surgery, and they take it for 7 days afterwards to help with that, that prolonged postoperative retention. So I'm really excited about this. Hopefully you all will follow up and read the prospective study when it's published. I think it should be soon. So really great news, great study, and really good job, Dr. Wannamaker.
Thanks.
Okay. How do we get on? Oops. Okay, where's my other one?
Dr. DeVoe, did you have something you wanted to add?
I did. There are a couple of concerns. I'm not a urogynecologist or female pelvic reconstructive surgeon, although I was trained to do some of those procedures in residency. I think that's my disclaimer. I think when you look at using drugs in an off-label way, this is a particular drug that has a significant occurrence of dizziness as one of the major side effects. And in dealing with an older patient population who are more at risk for postural hypotension and dizziness anyhow, I think one has to really evaluate the kind of patient that should get this to begin with, and do this on a patient-by-patient basis. Because the older patient that gets dizzy may fall, suffer an injury, a hip fracture or something like that, which is the last thing that you would want. So I would really be very cautious about giving this to patients that are older.
Okay. Can everybody see my slides now?
Yes.
Okay.
Yes, we can see them.
Perfect. So I am Lauren Griswold. I'm one of the third-year residents for those I have not met. And the study I looked at today was this article that was recently published this month, actually, in Female Pelvic Medicine and Reconstructive Surgery, which looks at the risk factors for dislodgement of vaginal pessaries in women with pelvic organ prolapse, a cohort study. So pelvic organ prolapse, just a quick review, is a common pelvic floor disorder. It has risk factors that include parity, vaginal deliveries, age, obesity, connective tissue disorders, menopausal status, and chronic constipation. We stage pelvic organ prolapse using a POP-Q. This image here is obviously not the correct way to stage pelvic organ prolapse, but it was the first thing that came up on Google, and so I thought it was interesting because this is probably what some patients are seeing when they Google what is prolapse. So stage 4, uterus is completely out of the vagina.
Lauren, your slides are not advancing.
Oh no.
Yeah, we
we're
can
not
only
in
see
presenter
your
view.
intro
Yeah.
slide.
Okay. How do I fix that? What are you?
You're advancing now.
Okay. I
I
might
think we
have to
see
do it.
background slide.
I did Google Slides, which maybe is my issue.
There should be a presenter view. I think you're, or in a,
That's what it did when
okay.
it did that. It wasn't working.
Hmm.
Can I just do it like this? It's not
Sure.
ideal, but okay. So what was up there was, this is what is seen when people Google pelvic organ prolapse. But this is the correct staging of pelvic organ prolapse based on the POPQ. And so today we're going to talk about treatment option for pelvic organ prolapse, specifically stages 3 and 4, and specifically vaginal pessaries. So obviously we have different options for treatment, including expectant management or do nothing, vaginal pessaries, or surgery. So vaginal pessaries are first-line treatment for pelvic organ prolapse in women that don't want surgery or have contraindications for surgery. They have been proven to improve quality of life scores, sexual function, and body image, but failure to retain a pessary is often associated with pessary discontinuation. And there have been several studies in the past that have looked at factors that might be associated with pessary failure, but these studies usually vary in the type of pessary that's used, population characteristics, and follow-up period. There's not really a great standard. And so just for fun, these are some old pessaries. This one on the left is actually a bronze pessary from ancient Rome. Definitely a ring pessary without support, I would think. In the middle, this is a pessary from the 1890s. It's made out of boxwood and ivory, which I feel like would not be super comfortable. And even more uncomfortable appearing is the one on the right, this cup and stem pessary with a belt included. So just some historical fun facts. So overall, this was a cohort study. It was conducted in a tertiary urogynecology center in Brazil. The objective of the study was to evaluate the factors associated with ring pessary dislodgment in women with advanced pelvic organ prolapse. So more specifically, they focus on symptomatic advanced pelvic organ prolapse, which they defined as noted in my little box over here, as anterior posterior apical stage 3 or 4 prolapse based on the pelvic organ prolapse quantification system, or POPQ. Women with symptomatic advanced pelvic organ prolapse who chose conservative treatment with a pessary were eligible for the study. And then any woman that subsequently requested to have their pessaries removed during the 6-month follow-up were excluded. Since they chose removal, it didn't just fail on its own. So again, it was women with symptomatic advanced pelvic organ prolapse who chose to proceed with non-surgical management with pessary were identified and recruited. A ring pessary without support was the only type of pessary used, which is pictured here. They had 10 different sizes with different diameters, and so they would see the patients in the office and place the pessary in the office, and then have the patient walk around and perform Valsalva maneuvers to make sure the pessary was comfortable for the patient and that it wasn't displaced immediately during that office visit. If the pessary did become displaced in that initial office visit, they would replace it or try the next size up until they found the best fit or the largest pessary that was the most comfortable. So that was the first time they saw these patients. Patients were not allowed to remove and clean the pessaries at home as some of our patients do. They had to go into the office. And then they followed these women for 6 months, and women who had their pessaries dislodged within those 6 months were then placed in the dislodgment group, and they were compared to those patients who were able to retain their pessaries. As far as statistical analysis, they compared the two groups of patients to identify factors that may be associated with pessary dislodgement, using the Fisher-Exact test and the Mann-Whitney test to analyze variables, and then use logistic regression models with univariate and multivariate analysis to evaluate which variables were independently associated with the frequency of vaginal pessary dislodgement. So, starting with some of our results, they evaluated a total of 98 women. 5 of them were then excluded, 3 because of pain discomfort, 1 opted for surgery, and 1 was lost to follow-up, leaving a total of 93. Of these 93 that were followed for 6 months, 78 of them, or 83.9%, were able to retain the ring pessary during the 6-month follow-up, and 15, or 16.1%, failed to retain the pessary. And all of these 15 women actually experienced pessary dislodgement during the first week of use. So here are the demographic and clinical variables of the women in both groups, the retained and the dislodged. You can see that there's no difference in age, BMI, parity, schooling, race, menopausal status, comorbidities, or sexual activity between the two groups. There's also no difference in vaginal length, genital hiatus, or perineal body size. It was noted that women whose pessaries became dislodged had significantly more previous reconstructive surgery with p-value of 0.009, specifically anterior colporrhaphy, I can never say that word, with p-value of 0.035, and a more advanced POP-Q-C point, apical prolapse, with a p-value of 0.025 than women that were able to retain the device. They then did the univariate analysis to look for associated variables with vaginal pessary dislodgement, and again identified the previous pelvic organ prolapse surgery, as well as abdominal hysterectomy, anterior repair, and stage 4 apical prolapse. They then did the multivariate analysis to exclude confounding factors, and after that, only previous pelvic reconstructive surgery with p-value of 0.003 and stage 4 apical prolapse with p-value of 0.008 were the only factors that remained associated with pessary dislodgement. So based on these results, the authors wanted to compare their results to prior studies. So according to these prior studies, there is a really wide range of successful continuation of vaginal pessaries reported, from 41 to 86%. And this is likely due to study differences. Different studies had different definitions of what successful continuation was, and also different follow-up duration. So overall, this study that we are looking at had an 83.4% success rate, and they define success as pessary retention over 6 months. There's another study by Maeto that had a similar success rate, and they define successful pessary use as the patient returning at least once after insertion with no expulsion. They don't really specify how long or when that follow-up return visit was, but they just had to show up once without the pessary being dislodged. There's another study by Panman who had a 58% success rate, and they defined it successful pessary use as having the pessary comfortably inserted and keeping the pessary inside during Valsalva maneuver for at least 2 weeks. And then another study that had a 41% success rate over a 3-week follow-up. So obviously there's been a lot of variability in all of these studies, which I think has contributed to these varying success rates. And then just one other thing to note is that in this study, all 15 of the patients in the dislodgement group had pessary displacement within the first week of placement, and most other studies found similar results, that people that were unable to retain their pessary, it came out within the first 1 to 3 weeks after placement. So the study found that previous pelvic surgery presented an 8-fold risk for pessary dislodgement that they thought might be associated with architectural changes of the vaginal canal after surgery, in addition to changes in the mechanical properties of the vaginal soft tissue introduced by tissue fibrosis after surgery. There was another study that actually looked, they also found prior vaginal surgery was a risk factor and looked at the odds after multiple surgeries. And so they found that after one previous surgery, the odds of pessary expulsion was 18.8%. And then after 2, the odds increased to 27.3%. Something that was different about this study compared to others is that this study did not find any association between dislodgement and BMI, parity, vaginal length, or introitus size, which other studies had found. And so this was different from those studies in that way, which is another thing that all of these studies found very different findings. It also found that apical prolapse, women with apical prolapse were at 13 times higher risk for pessary dislodgement, but this was similar to other studies. So some similarities, but lots of differences. The study strengths were that it used a single pessary type, a ring without support, which is the most commonly used pessary worldwide, whereas other studies looked at different pessaries, and they definitely had the longer follow-up duration of 6 months. Most studies had a shorter follow-up. Limitations, some people might still consider 6 months as a short follow-up. Since there was such a low rate of pessary displacement, it might have impaired the analysis, and that there are other variables that should be associated, but weren't due to the low number of events. So there's definitely a need for more studies with more patients and longer follow-up. So conclusions, and I can't spell dislodgement. A dislodgement of a ring pessary was low within 6-month follow-up. Pessary failure within the first 1 to 3 weeks is useful to help counsel patients of what to expect. And then advanced apical prolapse and previous pelvic organ prolapse surgery are risk factors for ring pessary dislodgement. Here are my references. Are there any questions? Okay.
That was a really good job, Lauren. Sorry, this is Dr. Jennifer Lanzer. So how would the results of the study, how would this change how you would counsel patients who were interested in pessary?
I think that I would be able to, if they've had previous surgeries before, especially people that have had multiple vaginal surgeries, that they were at a higher risk for pessary displacement and failure. And so it might not be the best option for them, but that if they were willing to try it for at least a month, they would have a good idea if it was going to work for them or not, since it seems like most patients that are going to fail within that first week to first month.
Okay, I think that's really good. I think that, the other thing that we sometimes, if you're concerned that a patient may be in one of those high-risk groups, since we know that they'll probably fail sooner, sometimes we see them back, maybe in 2 weeks, maybe in 4 weeks, instead of just saying, we'll see you back in 3 months, kind of our typical follow-up, so we can see them back sooner, in kind of providing them a little bit of reassurance. Now, it is interesting, I think typically when we're kind of talking clinic, and I've certainly found in my clinical practice, very much so that the larger introitus and the shorter vaginal length are definitely associated with increased pessary failure. If you look at the patient demographics, their patients actually, I think like the average vaginal length was like 9 and their average introitus size was somewhere around 3. So like they didn't have, you know, an average introitus size of 6 and a, you know, a vaginal length of 4. So they may just not have picked up patients that had kind of those really difficult vaginas to fit, because again, it was kind of a small sample size, particularly in the dislodgement group. The other thing is, what do you think about their selection of pessary and the fact that they saw increased dislodgement with advanced apical prolapse?
I guess the ring without support wouldn't be the best option for someone with advanced apical prolapse. So that could have contributed to it, that there's other pessaries that would be better.
Yes, and so sometimes I think that this could also affect your pessary selection, right? So if you have a patient that's had multiple pelvic surgeries, has advanced apical prolapse, this may not be the patient that you reach for the ring pessary first. This may be a patient that maybe you want to fit with a Gellhorn or a space occupying pessary, something like that. So I think that it kind of also affects how we would possibly approach the pessary fittings of patients. One of the things that I wish they had included in the study, since they used all the same kind of pessary, is I wish that they included like the average pessary size for the different groups, because I just think that would have been interesting to know if the dislodgement, you know, was this all patients that were using just the gigantic pessaries that they had to fit. Because I think that that's kind of interesting too. Like if you have to fit a patient with a very, very large pessary, would you counsel them, you know, this is definitely something that would be an increased risk of failure? I think that because they were using the exact same kind of pessary, that would have been interesting to know. That would have been an easy thing to kind of mine from the data. But I think that you're right. I think pessaries, I think I'm very reassured that, you know, this shows that pessaries are a great option for patients. You know, even in patients that have had multiple pelvic surgeries, they still, the majority of them still do well with pessary. And I think that, again, you know, as we talked about in the previous article, a lot of this is patient satisfaction, and patients that have a good fit with their pessary there's been some studies that show that they're more satisfied with pessary than they are with surgery. But the whole issue is the patients that are not satisfied with their pessaries are usually very unsatisfied with their pessaries. And so getting a good fit and trying to minimize dislodgement and counseling patients appropriately increases patient satisfaction with pessaries and overall. And so I think that these studies that look at risks of dislodgement are important, because it affects how we counsel patients, and it affects their you know, overall outcomes and satisfaction. It was a really good job, Lauren.
Thank you. Okay.
Do we have any other questions for Dr. Griswold? All right, hearing none, we will go ahead and dismiss for today, and thank you for your attention.
Thank you.